Gus. Thank you so much for joining us for another Wednesday VMR. I'm so excited to facilitate with my good friend, buddy Jack. And thank you for
Hi.
joining us. Uh, hey, Jack.
Great to see everyone. Yeah, good to be here. I miss getting to do this with Charmise.
Yeah, it's going to be fun. Well, it's going to chat some medicine. Does anybody have a case that they want to share? Amazing. We have a case. Hi. Jasdeep, I might be mispronouncing your name, but do you want to unmute? It's so nice to meet you. Do you want to unmute and introduce yourself to the crew?
Yeah, sorry. My name is Jasdeep or Jazz. Some of the VMR folks know me from a recent case I presented on Friday, like a couple of Fridays ago. I have been a follower of the clinical problem solvers for the last 3.5 years. I've listened to Jack and yourself, Charmaine, like when like the clinical problem solvers was a podcast on Spotify. So it's an honor to present this case today to you guys.
Oh my gosh, Jazz, it's so nice to meet you. I'm sad I missed. I have to go back and listen to your case now. Thanks so much for volunteering, and it's so nice to meet you. Thank you for being here. I'm sure we're gonna become Jack and I big jazz fan right after this. So we're really excited that you're gonna present the case.
Excited to present as well.
All right. Should we just get the whiteboard up? And Jack, do you want to take the first aliquot?
That sounds good. The butterflies are starting to take flight in my stomach. Jazz, it's so great to see you. And thanks so much for bringing the case today.
Of course, you and me both. The butterflies are swimming away or flying away right now. All right. I'll wait for the whiteboard.
Oh, promise. I got you. Sorry. Give me one sec. That was my bad. All right. You should be able to take over now. Thanks, Austin. Thank you. Thank you. I activated the touch up my Zoom feature to really make it all look like one consistent unit. I'm really glad it's going to be on YouTube now. I'm realizing. Wonderful. All right, let's go ahead and get started with the case.
All right. Everyone ready? Okay. So this is a 76-year-old female that is presenting to the hospital for abnormal lab. So I can give a little bit more HPI. So it seems like she lives at home with her son, her older son that takes care of her, but he went out of town for the last 5 days and came back to the house and noticed that she was confused and kind of really weak. And he was concerned that she hasn't been taking good PO intake and was also questioning whether she took her medications or not. So took her to the PCP, who got a BMP, which revealed the following. A sodium of 145 and a potassium of 2.5, so that's low. Chloride was normal at 98. Bicarb was elevated at 37. A normal anion gap of 10. A elevated BUN of 26. Creatinine was elevated at 1.52. The last one was done about 8 months ago and it was 0.8. And then glucose was slightly elevated at 169. And I'll pause there for now. That was how she initially presented to the hospital.
All right. This is an awesome place to start. So I would say, I think as Maddie was alluding to in the chat here, right, we can sort of start to define the problem that we're dealing with based off of these labs that Jazz gave us. And the things that are really standing out here include an AKI, which may allow us to make some progress, but almost certainly this degree of hypokalemia in the setting of an acute kidney injury is probably going to allow us to make much more progress. And the reason I say that is if you think about all patients that you've seen who develop acute kidney injury or potentially one that progresses to acute renal failure, go ahead and put in the chat whether or not you more commonly see hyperkalemia or hypokalemia. Wait for some chats to come through. Yeah, exactly. So oftentimes AKI is going to come with hyperkalemia because when the kidneys take a hit, their ability to filter and excrete and get rid of potassium from the bloodstream is going to also take a hit alongside it. So the fact that we're seeing hypokalemia in the context of an AKI makes the hypokalemia dominate the center of gravity even more. And there's many ways that we can potentially approach hypokalemia. We can think about it mechanistically, asking ourselves, is the hypokalemia being shifted into cells, which we sometimes see, for example, in the setting of insulin use? Are we having renal losses of potassium, or are we having GI losses of potassium? So that's one way to frame it. Another way to frame it, which might be particularly helpful in this case, given the profoundly elevated bicarb here, is to ask ourselves how the pH can help us narrow the DDX for hypokalemia. And when we think about somebody who has hypokalemia in the setting of a metabolic alkalosis, we can ask ourselves one primary question up front, which is that is the person losing chloride-rich fluid? When we lose chloride-rich fluid, we will also thus be losing acid as a result of that. And the body tries to overcome that by normalizing the pH. And the victim of the body's attempts to normalize the pH or normalize an alkalosis is potassium. And so when somebody has large amounts of upper GI losses, like from vomiting or NG suction, right, we can potentially see hypokalemia in the setting of a metabolic alkalosis. The other time we see it is when we give people, for example, diuretics that may clear out their that may lead them to lose chloride-rich fluid. For example, patients who have heart failure who are given Lasix may develop a contraction alkalosis as well as hypokalemia as a consequence of that. But again, the AKI that we see here, again, makes me think that there's potentially a third sinister or potentially sinister cause underneath the surface here, which is going to be that the hypokalemia is driven by not necessarily GI losses or not renal losses, but potentially inappropriate elevation of aldosterone, which can come from a variety of different reasons. And we can think about looking for some clues there, but hyperaldosteronemia can sometimes come with the presence of hypokalemia as well as a metabolic alkalosis. And so I'm curious to hear from you, Charmaine, is there anything else that's jumping out to you from the information that we have here that can help us make progress there?
That is beautifully discussed in regards to the hypokalemia. I totally agree. The other question I'm asking myself then, why is this patient altered? Hypokalemia is not necessarily something I associate with altered mental status. So is it the AKI? Is it, that BUN is not that impressively high, but again, like everything in medicine is the delta that matters. So, from her baseline 0.8 to 1.5, that is an elevation. So is it in the setting of AKI, or is there another reason why this patient is altered? So whenever we think about our altered mental status, we think about MIS, metabolic, infectious, structural, and toxins. So I would keep that in mind as Jazz gives us a bit more information about who the patient is to, hold that one question is like, so 3 questions, right? What caused the severe hypokalemia? What is causing the AKI, and the altered mental status? So those are the 3 things that I'm keeping in mind as we go through the case. So Jazz, I'm excited to hear more.
Awesome. Brilliant discussion by both of you, like always. All right, so I'll give you guys the past medical history and meds. Just give me 1 second here. So she has a past medical history of Lewy body dementia. She has history of colon cancer that was about 8 years ago, that was treated with surgery and chemotherapy and has been in remission since. She also has a history of atrial fibrillation on Eliquis, history of type 2 diabetes, hypertension, hypothyroidism, and orthostatic hypotension. She takes the following medications. She takes donepezil 10 milligrams, Florinif or fludrocortisone 0.1 milligrams twice a day. She takes omeprazole 20 milligrams for acid reflux, levothyroxine 75 micrograms, gabapentin. She is on long-acting insulin, 12 units nightly. And that's basically it for the relevant medications. There's a bunch of other stuff too. In terms of social history, I kind of gave you guys a little bit of a context. She lives with her son. She is like only partially independent. Like she can bathe herself and do like minor tasks around the house. It pretty much depends on the son for like making meals and going to appointments and even medication administration. No allergies, no relevant family history. In terms of vitals, her blood pressure initially in the ED was 213 over 97. Pulse was 69, which was normal. She was afebrile. Respiratory rate was normal at 16. She was satting 98% on room air, and her BMI was 21. Her blood pressure did eventually come down a little bit to like 160, 170. So it wasn't as high as 213. But yeah. Do you guys want me to pause there, or do you guys want a little bit more information?
Do you want to just take us through the end of the exam and pause there?
Sure.
Thanks.
Rest of the exam was completely normal. So she was at her baseline of AO times 3. She was not confused on our examination. Her heat exam did not reveal any abnormalities. Regular rate actually, she was in regular rate and rhythm. Was not in AFib when we examined her. Clear to auscultation bilaterally. No abdominal pain or tenderness or masses. We did not do a thorough neuro exam other than the AO times 3, and then there was no skin rashes or anything like that.
Yeah, thanks so much. That's such an interesting case. So, just like looking back the past medical history and the meds, I'll pass along the mic to Jack afterwards for his thoughts. So, one thing that jumps out of me again, like few parallel things. We need to explain this hypokalemia, but also in the setting of altered mental status, I want to make sure I'm missing my no misdiagnoses. And someone with a history of AFib on Eliquis who has orthostatic hypotension to begin with, one thing I worry about is falls in the setting of someone who hasn't been with, who's been alone at home. So this is someone that I would get a non-con head CT just to make sure, again, structural causes of altered mental status that we rule that out. So that is again, your no misdiagnosis that you want to do. And the other day we were having a discussion about orthostatic hypotension on rounds and how challenging it is to manage that, especially in people who have supine hypertension. Corticosteroid or other meds that we give, it can make supine hypertension worse and questionable if they really help with actually orthostatic hypotension, and it's a very challenging diagnosis to manage. So that is something that I worry about if she's alone taking too much of that medication, and that would explain the excess that we are seeing here. So something to keep in mind. The other things that are considering, like gabapentin taking too much, her glucose is 169. So even if, I'm not too much worried about she's taking too much insulin at home. But, I think those things jumps out to me in her past medical history and meds. I'm curious to see what jumps out to you, Jack.
No, I appreciate so much the taking the sort of, there's the diagnostic ways that we may approach this, but then also the sort of the enactment of this, because we could go down, I think, like a very interesting diagnostic path with some of these laboratory and vital sign findings that are emerging here, but also the practicality of, like, this is an elderly person who's been home alone, who has been altered. There's far more probabilistic things to at least evaluate before we start to run down the path that I am now, as I say that, gonna at least lead us down cognitively as we think through this. And I think, we had mentioned sort of early on 3 signatures of disease to look for in regards to the hypokalemia. Those signatures of disease being GI losses, renal losses, as well as the possibility for excess aldosterone levels. And a real clue here, as Austin alluded to in the chat, that can lead us down the path of potentially inappropriate aldosterone levels is the fact that there is such profound hypertension here, and somebody who we know has had maybe a predisposition towards hypotension with the finding of orthostatic hypotension, although she does also have a diagnosis of underlying hypertension. But I will say, for me, when I think about the things that may happen to an elderly individual who's been home for some period of time, one of those could be missed antihypertensive meds, but another one could be low PO intake. So I am quite struck by the degree of hypertension here in the setting of the other laboratory findings that we had, which were AKI as well as hypokalemia. And so if we're going to pursue or possibly think about pursuing the possibility of excess aldosterone here, we have to ask ourselves, well, how can we really confirm that hypothesis? And there's really 4 clinical features that will give us a clue to the fact that there is inappropriate hyperaldosteronism. We have 3 of those 4 clinical features so far. 1 is going to be an elevated serum bicarb level. 1 is going to be a low potassium level. The 3rd is going to be hypertension. And then the 4th that we need is going to be an elevated urine chloride. If we do end up finding that this individual has an elevated urine chloride level, we can go down the pathway of increased aldosterone levels. Now, one way to think about that would be to say, is the renin low, or sorry, what's happening with renin, what's happening with aldosterone? And depending on if both are up, one's up, or neither are up, we can go down that path. But practically, that can be really difficult to do, because somebody who's potentially had low volume intake, who's also hypertensive, who may be taking renally active medication, those can really impact how the renin and the aldosterone levels are going to be, how high they're going to be in the serum. So the other thing that we can think about is potentially thinking about mechanistic categories of things, whether that could be an underlying mass that could be secreting hormones, or some chemicals that may be ingested that can lead to the mimicking of certain hormone syndromes. Before we go down the inappropriate aldo schema, we always want to at least evaluate for the possibility of one of the rare things that cause hypokalemia, like Bartter or Little's, or Little syndrome. But the fact that there's so much hypertension here tells us that this aldosterone level is probably inappropriately high. And so I think at this point in time, and alongside the things that Charmaine mentioned, I think my VA Wi-Fi is cutting out a little bit here. Am I back?
Yep, we can hear you.
Okay. So in addition to pursuing those things that Charmaine mentioned, seeing if maybe the urine chloride is particularly elevated, and then potentially going further down the path of elevated aldosterone levels here, maybe one way to sort of explain the lab findings as well as the hypertension.
Awesome. Amazing discussion. I also want to shout out the chat. Like, you guys are all brilliant. Some really great ideas and thoughts. So for this next set of information, her CBC was normal, nothing really contributory there. I will give you guys another, like, we repeated some of the outpatient labs again. So her sodium was a little bit elevated now, 147. Potassium was still low at 2.9, and it still had a bicarb of 33. Serum creatinine did come down a little bit to 1.23, and yeah, the rest are pretty much similar to the outpatient labs. We got a UA, which was a specific gravity was normal, 1.014. Trace amount of glucose, no ketones, no blood. pH was 7.5. Protein was 3+, but that is not new. She's had that in previous UAs. No nitrites, no leukocyte esterase. We did get a urine chloride right off the bat, and it was at 126. So that was high. We also did get a CT scan of the head. That was a great point by Charmaine, just because of her history of recurrent falls, and it showed no acute intracranial hemorrhage or any other structural abnormalities. We also got an EKG, which did not show any flattened T waves or U waves, and no prolonged QRS. We did not get a chest X-ray. I will share the aldosterone level, and then I'll pause there. We are pretty close to the end of the case. The aldosterone was low, or like not high. Yeah, I'll pause there for further discussion, and then I do have like some like very brief teaching points at the end.
Jazz, I just want to say this is a phenomenally laid out case. Like the thought, the intentionality. I feel like there's almost like I can almost hear in the way that you're laying out like the different objectives within each case aliquot. So I just want to say I appreciate so much where you've chosen to make the branch points here and the way that you've sort of walked this forward. It's making for a really, really fun case to discuss. So thank you for that.
I appreciate you saying that, Jack, because last time I was a nervous wreck. So
oh no, this is, I mean, like I get like it's you're stopping, like there's so much tension held at every stop point. I'm like leaning further and further forward with every aliquot. So thank you. I think I will just sort of comment briefly on where some of these labs can take us to, and then I'll kick it over to Charmise to take us to where we may be within the hyperaldo schema here. So I think the elevated urine chloride, along with some of these other findings here, like the sodium, the low potassium, the ongoing alkalosis, all put us into a picture of inappropriately elevated aldosterone, which is confirmed by the fact that we have such a high aldo level, which is curious given that we have a low aldosterone level that we saw on the labs here. In terms of if we were to just pretend for a second that we were dealing with this case before we had the aldosterone level back, there's really two knobs that we think about in terms of the evaluation of a syndrome that suggests inappropriate aldosterone activity, right? Not necessarily definitely inappropriate aldosterone levels, but at least activity in the body that's mimicking mineralocorticoid excess. And the two knobs that we think about are going to be what's the renin doing and what's the aldosterone doing. In some cases, you might see really, really high renin and really high aldo coming together. In some cases, you might see low renin and high aldo. And then in a case like this, we're grappling with the finding of actually low aldosterone, despite what seems to be a syndrome of mineralocorticoid excess. Things that can cause both renin and aldo to be high are going to focus on the kidneys, primarily things like renal artery stenosis, patients who have scleroderma. This is the picture of scleroderma renal crisis. And then if somebody potentially has a renin secreting tumor, that excess renin level will then go on to activate the secretion of aldosterone. So really inappropriately high renin states will lead to inappropriately high renin and aldosterone levels. The second scenario that we find ourselves in is when the renin is low, but the aldosterone is high. And this is basically when you have excess aldosterone secretion that's left the normal feedback loop of renin and aldosterone levels. The things that we can sometimes see with this would be someone who has, for example, an aldosterone secreting renal or adrenal tumor, or for example, someone who may have adrenal hyperplasia, as well as a variety of different familial syndromes like congenital adrenal hyperplasia, for example. And then we get into the space of low renin, low aldo, which we sometimes call apparent mineralocorticoid excess. It seems that there's too much mineralocorticoid on board, but in fact, we discover that the aldosterone level is low. And for that, I will turn it over to Charmise to take us through some of those pieces, as well as anything else that I may have overlooked in my excitement about this case.
Yeah, Jazz, I just want to echo what Jack said. Brilliant case presentation. I'm so glad we get to do this together today. Jack, that was awesome. Yeah, so we have evidence of hyperaldo activity, but the aldo is low. Medicine is really, really cool. So what does that tell us? It's both the renin and aldo is that our endogenous system is like being suppressed. So there is, when I think of that, I think about mineral apparent mineralocorticoid excess. So a couple of things that come to mind. A, is the patient taking some hint, that med list with the food record? That's something to consider. The other things to think about is like little, I have no idea how to say that, syndrome, but that's, often I think of people presenting at young age with hypertension. So I don't think this is, that's the case we're dealing with today. And then the other ones are more issues with kind of like the pathway, especially with steroids. So anything that causes like excess steroids, whether that is genetics, Cushing's disease, some medications like some of the azoles can do it. In this patient, I would say, exogenous intake is probably the one that I'm the most worried about. We're not really getting a flavor for like Cushing's in this case, not unlike posaconazole or in other medications that usually can do this as well. And so there's some like genetic causes as well. So my mind immediately goes to, the meds that she's taking with the fluid record. But I'm curious, Jack, is there anything else that comes to your mind that I haven't mentioned?
No, I'm with you. I think there's not really a great clear culprit for a lot of the other syndromes that you mentioned.
Oh,
I
yeah,
think one of the things
licorice.
that I'm
Sorry about that. I forgot the licorice.
boom, I love it. I think one of the things that I'm grappling with is the possibility of can we have glucocorticoid excess that could be potentially modulated by medication, but also from something happening endogenously. It's such a rare diagnosis, but I think one learning point that I've learned from missing this in the past is that Cushing's coming from, for example, something like ectopic ACTH secretion can sometimes have the metabolic phenotype of Cushing's without necessarily the physical exam findings that we may associate with Cushing. So, for example, in ectopic ACTH production, someone has an underlying tumor or some sort of neuroendocrine or hormone secreting malignancy that produces ACTH that then leads to an activation of the entire adrenal system, but they won't necessarily show the typical Cushingoid features like weight gain and striae for both because of the oftentimes the fact that there's underlying inflammatory disease, so they may not gain weight in the way individuals with Cushing's may gain weight, and usually the syndrome presents for some reason for a very much quicker than Cushing's may, and so there's not enough time for some of the other characteristic skin findings like striae to manifest. And so if we end up finding that the most likely culprit that Charmaine mentioned doesn't allow us to make progress, that may be one place for us to explore after the fact. But I'm with you. I think there's a potential culprit for this on the med list, like you had mentioned, as well as ingestions to explore before going into that space, which the base rate would say should be one of the later places for us to explore, given that there's no real clear sign of underlying malignancy based off of what we have so far.
Boom! That was such a brilliant point, Jack. I love it. Absolutely phenomenal. I'm just curious, Austin, are you in a good place? You made some great point about the orthostatic hypotension. I was wondering if you wanted to share that learning with everybody else.
Sure, can you hear me?
Yeah, hey, Austin. Thank you for all the brilliant points in the chat.
Oh no, you guys crushed everything. I didn't add too much. I did learn this kind of point from one of the grand rounds that we had a couple of years ago about, it was a geriatrician from I think last January, and he was talking about the management of orthostatic hypotension and just the as you mentioned, Charlene, just like the big challenges that come with that, and he brought this point about treatment of hypertension and orthostatic hypertension, and I was like, this is so confusing. Like, how could it possibly be beneficial for patients to treat their hypertension? But really, this point is that their outcomes and even mortality is better when you manage their hypertension, and even their symptoms of orthostatic hypertension are improved by managing their blood pressure. And it seems to be in particular with ACEs and ARBs. And so mechanistically, I have to say that the mechanism is escaping me. I think it's in the paper that I wrote, so I don't know exactly what it is, but I have had some success with this clinically, like NF2, where patients we can get their blood pressure at least a little bit better managed, but really it's more about the sort of non-pharmacologic recommendations as far as when you're being supine, watching kind of what you're doing when you're eating, how when you're standing up, using abdominal binder, that sort of thing. But just a small, interesting point that I think many people haven't necessarily heard of. At least I certainly haven't before.
That is so brilliant. Thank you so much, Austin, because we see that so often and it's so relevant. So I loved it when you put that in the chat. Thanks so much. As always, Austin, always a pleasure having you here. Jazz, do you want to take us away?
Sure. That was amazing. Also, there was some hate towards black licorice. I guess I'm the only one that liked the black licorice jelly beans, but anyway.
Good and plenty's all the way. Good and plenty's all the way.
I actually did ask the patient if she takes licorice, and she just looked at me like, what? So apparently no licorice use. So yeah, you guys like nailed it from some of the chat, nailed it from the very beginning, and you guys also mentioned it too from the, I think, like the second aliquot. So we asked more about the Florinif use at home, and according to the son, that he was appropriately giving it twice a day. It seems like she, again, her baseline mental status is questionable, but she says she was taking it 4 times a day, those 4 days, 4 or 5 days that the son wasn't home. But before we got that information, we were also concerned about primary hyperaldosteronism, but we looked back at our previous BMPs. What really clouded the picture, what made this case a little bit more interesting, is that sure, she had this Florinif use, but she also had hypertension, and we looked at her outpatient charts, and she's had hypertension basically the last decade. So we're like, okay, maybe this is primary hyperaldo that hasn't been diagnosed, because we all know that it's like one of the most common missed secondary causes of hypertension. So we tried it. That's when we got the renin and aldo, and then when we saw it was low, we're like, okay, so this might be Florinif. But we also sent a DHEA sulfate level. Something I learned during this case, that extremely high levels can also may indicate adrenal corticoid carcinoma, which is rare, but if it does present, it's something that you don't want to miss, and can present exactly like this patient with the low aldo. And the other thing is, there has been case reports with orthostatic hypotension associated with primary hyperaldosteronism. So which is why we kind of was wondering, could this be it? We decided not to get any abdominal imaging just because the DHEA sulfate was normal. Once we held the Florinif, slowly her electrolyte abnormalities improved. We did start spironolactone, but I followed up after she got discharged. She was no longer on spironolactone, and her electrolyte abnormalities have normalized. So yeah, basically in this case, what I learned was, if the aldo is low, it's either it could be like a genetic abnormality, but in this case, less likely for her to get diagnosed with a genetic abnormality at 76. And we learned that it's either a tumor that's secreting the aldo, not the aldo, another type of mineralocorticoid, or an excess ingestion. And in this case, we were able to pin that to Florinif. But licorice was obviously a great side pill too.
That was brilliant, Jazz. Loved your teaching points. Hyperaldosteronism, or like this tumor, is causing orthostatic hypotension. I did not know that, so thank you for teaching me. This was such a great case. Thanks for presenting. Thanks, all. Chat was crushing it. I sometimes feel like the Jazz just does the way better discussion than I do, so thank you for supplementing it. Anything else, Jack?
No, this was just so much fun, Jess. Thank you for bringing such an amazing case, and again, like the deliberateness and the intentionality with how it was presented. And yeah, I mean, the chat, as always, was just packed with pearls. This is I agree with Maddie. This is one to go back and listen to, and I'm definitely going to reread the chat for this one. I learned a ton. Again, it's like that my favorite space to be, where it's like getting to practice what we have some understanding of, and then find tons of spaces where the understanding can get filled in even more. And what better way to do it than with friends? So this was a great way to wrap up the day. Thanks so much, everyone. I'm realizing I just trailed off there and didn't actually hand the mic over to Mukund. So Mukund, you want to take it away for teaching points? I'm all over the place today. Please take us home.
Totally fine. Yeah, we'll be quick. This was a fun case. Really getting some new perspective on clinical reasoning now that I'm in third year. But this was cool. We talked about a 76-year-old woman with severe metabolic derangements, hypokalemia in the setting of AKI. So we went through a differential for hypokalemia. We narrowed it down to 3 big boxes: intracellular shift, losses in the kidney, and losses in the GI. And we talked about how urinary chloride can help us differentiate between many of these causes. We went on to talk about differential for elevated mineralocorticoid type activity given this patient who has profound hypertension, hypokalemia, and a metabolic alkalosis. So we talked about high renin and high aldosterone causes, including renal artery stenosis, scleroderma renal crisis, and renin secreting tumors. We talked about low renin and high aldosterone causes, such as Conn syndrome, which is an aldosterone secreting tumor. And we talked about low renin and low aldosterone, which is a pretty extensive differential. But we zoned in on the fact that she was taking fludrocortisone, which is a mineralocorticoid analog, and found that because of her low serum aldosterone, that this was the most likely culprit. So that's it. Thanks, everyone.
Amazing wrap up to the case. Thank you so much, Mukund. And thank you all so much for joining us. We will see you next week.
Yeah, we will. Bye, all.
Bye, y'all.